Hello, I'm Dr. Phillip Scheinberg. I run the Division of Hematology at a Hospital Beneficencia Portuguesa in São Paulo, Brazil. And I have a lot of interest and have spent a lot of my clinical and research career in marrow failures and aplastic anemia. And for the next 45 minutes, I will be sharing with you a little bit about what is known about the disease and some of the recent advances which have been important in aplastic anemia. If you have any questions, feel free to send them in the chat format during the presentation, and I'll be more than happy to address those as we go along. So the idea here is that we do something iterative and that is productive and informative for those, all of those in attendance. So these are my disclosures. And here's the bone marrow of a patient with aplastic anemia. So this is a problem. This is an empty bone marrow. And this is what you see in the idiopathic acquired aplastic anemia when you do see pancytopenia and a hypocellular marrow. Remember that the diagnosis of aplastic anemia is usually one of exclusion. So it's important to rule out other causes. This is the bone marrow actually from the same patient. And as you can see on the left, it's a much more healthy looking and cellular bone marrow 6 months after immunosuppressive therapy. Now remember, and I always like to remember people that aplastic anemia has been for a long time, since its description in the late 19th century, a deadly disease, meaning that most patients died of aplastic anemia, of infection complications and bleeding complications. So the mortality historically is very high, particularly in those patients who had very low neutrophil counts, reticulocyte counts, and platelet counts, which actually established the criteria for severe aplastic anemia about 30 years ago. So we know that these patients are at higher risk of dying. But aplastic anemia has company. It's not alone. It's part of a group of disorders called the bone marrow failure syndromes. And although they do have some distinct characteristics, they also have some overlap. And I think it's important for those listening in to appreciate some of these overlaps. If you look, for example, in yellow aplastic anemia and in orange PNH, we know that 40 to 50% of patients with aplastic anemia have a PNH clone, usually small, less than 10%, but it can happen in about half the patients. We know that patients with PNH can always have some degree of marrow insufficiency. And we know that 20% of patients with MDS present with a hypoplastic marrow, which creates the entity of hypoplastic MDS. And we also know that about 10 to 15% of patients with aplastic anemia go on to develop cytogenetic abnormalities, MDS, and sometimes leukemia. So there are some overlaps syndromes here, but more importantly, and this is some of the new information, the last 10 years, we have appreciated that about 5 to 10% of patients who present in the clinic with idiopathic acquired aplastic anemia, no personal history, no physical abnormalities, do indeed have some genetic alterations, usually in the telomerase complex. And that was unknown until some of these patients were being tested systematically in the clinic, where we found about 5 to 10% of patients having a TERC or a TERT or a very short telomere length, indicating that they might have something else underlying. So it's important to appreciate that there are overlap in these diseases. The most prevalent and preponderant mechanism of action is immunologic, meaning that the immune system is perturbed and causes stem cell destruction and marrow failure. So we have had several laboratories around the world, in Europe and in Asia, as well as in the United States, showing an increase in interferon gamma, TNF secretion, Th1 related proteins and cytokines, reduction of T-regulatory T cells, increase of inflammatory T cells like Th17, expansion of CD8 toxic T cells, which all lead to the destruction of hematopoietic stem cells and subsequent pancytopenia and marrow failure. So when we talk about aplastic anemia, we're talking about this immune aplastic anemia. We're not talking about that patient who got chemotherapy and has an empty marrow. We're not talking about that patient who had radiation and has an empty marrow in their iliac bone. We're not talking about patients who have certain infections that can lead to a hypoplastic bone marrow. We're talking about idiopathic acquired aplastic anemia, the immune type. And these patients usually present otherwise healthy except for severe pancytopenia. So the diagnosis, as I mentioned, is of exclusion with a less than 30% cellular bone marrow, and criteria for pancytopenia, usually 2 out of the 3 counts I show here. Neutrophil count less than 500, a platelet count less than 20,000, and a reticulocyte count less than 60,000, depending on the method that is being used, less than 20,000. Automated machines nowadays are very sensitive, so the 60,000 cutoff is usually used. How do you approach patients with severe acquired aplastic anemia? Well, age is still the only factor we use to decide in the clinic. So if you're younger, less than 40, and you have a matched sibling donor, transplant should be offered and should be conducted. Transplant is curative, but obviously associated with risks. We know that patients up to 20 years of age tend to do better than those patients who are between 20 and 30 and 30 and 40. Why 40? Because the results in patients over 40 are not as good for transplantation. You know that the mortality in the first year or two in patients over the age of 40 is about 40 to 50%, which is high. And that's mortality, not taking into account morbidity. So the 40 cutoff is pretty well substantiated in the literature. For all of the patients who don't have a donor, or if you're older than 40, you should get treated with immunosuppressive therapy, usually in the form of ATG and cyclosporin. Now, this regimen of mostly horse ATG cyclosporin has been investigated in several continents, several countries, and what we've learned is that the overall response rate is about 60 to 70%. So roughly 2/3 of patients respond to immunosuppression, which is a very important surrogate for survival. What do I mean by that? If you respond to immunosuppression, you have a very high likelihood of being alive 2, 3, 5, 10 years from now. Now, this is important. You know, we're talking about a survival about 85, 90% long-term. So it really puts you in a very good risk category. First, because you respond and your counts get better and you don't have the risks associated with severe pancytopenia. But secondly, because you have an immunological mediated or responsive disease, which is important. We've also learned from these studies, which included hundreds of patients, as you can see, some of the limitations. Although it's a big advance, ATG cyclosporin, we've also learned that relapse can occur in about 1/3 of patients, and about 10 to 15% of patients actually can go on, as I mentioned previously, to other diseases. Survival has improved significantly. So this is really a success of modern medicine, where you have a disease that was almost universally fatal, changing the natural history of the disease to one that the majority of patients are actually able to achieve a hematological response and survive. So as I mentioned, there are factors that limit the success of immunosuppressive therapy. Unresponsiveness obviously is one of them. I mentioned that 2/3 of patients respond, so 1/3 don't, so that's a limitation. Relapse can occur in about 1/3 of responders. And 10 to 15% of patients who, with time, can develop clonal evolution. So let's focus on the unresponsiveness, because that is where a lot of the efforts have come in the last several years, trying to reduce the pool of patients who become refractory to immunosuppressive therapy and require more therapy or transplant or higher risk procedures. So what has been done? A lot of things have been done. What has worked? Actually, not much. And I'm just going to summarize this in one slide. Growth factors have been given with horse ATG cyclosporin. It has not been shown to be of benefit, surprisingly. Mycophenolate was added to horse ATG cyclosporin. That didn't do anything. Rapamycin also didn't do anything. Keeping patients on cyclosporin, which is a common practice among hematologists, doesn't seem to prevent relapse. It tends to delay relapse, but doesn't seem to prevent relapse. So we weren't able, and this is 7, 8, 10 years worth of research, and nothing actually has improved the response rate. Cyclophosphamide was attempted in 2 trials, and actually way too toxic. Severe neutropenia, fungal infections, and more recently, in the last 10 years, rabbit ATG and alemtuzumab were given frontline and compared directly to horse ATG in a 3-arm randomized trial. The results were reported about 8 years ago now, where the hypothesis was that these more potent agents would give more immunosuppression and would give more or a better result. So horse ATG was a standard control arm. Rabbit ATG, which is more potent lymphocytotoxic anti-lymphocyte serum, would give better results. The results were unanticipated and unexpected, and although horse ATG did exactly what it was supposed to do in this prospective randomized trial, the results with rabbit ATG were actually inferior, meaning that the response rate was about 40%, instead of the 65% that you see with horse ATG, which, as I indicated, correlated with the worst survival. So the outcomes here were surprising, and they were not anticipated, and we were not able to prove our hypothesis that giving more potent lymphocytotoxic drugs in the form of rabbit ATG was actually better. I did not show you the alemtuzumab data because we had to stop the alemtuzumab arm early, given the fact that after 16 or 17 patients, we saw only 1 response, and we had to, quit that arm. So the study was allowed to continue as a horse rabbit versus rabbit ATG arm. And the response difference of about 60% in one arm, 30%, 35% in the other, resulted in a survival difference, meaning that rabbit ATG gave us a worse survival. The EBMT, where I just showed you the American data, the EBMT did a propensity score matching data in Europe, where prospectively treated rabbit ATG patients on protocol were compared to age-matched horse ATG treated patients. And the results were very similar to that observed in the US trial, showing, again, unexpectedly, that the rabbit ATG was not even superior. It wasn't even equal to what we observed with horse ATG. So, these are 2 prospective data from 2 different places. Several other reports came out. Interestingly, some earlier reports had already indicated that horse ATG might be better than rabbit. So I'm just highlighting the prospective data. And for those of you who are listening in, you might be interested to know that actually the first trial that was done comparing horse and rabbit was actually done in Russia. And it was had a very small number of patients, but it showed a marked difference in favor of horse ATG. And I spoke to the investigators, and they in Russia a few times, and they said that they presented as a poster. I was able to find it, but it wasn't published because there was a lot of problems in the peer review process where the reviewers and editors weren't really believing the data. The N was very small; it was less than 20 patients, so I can understand some of the limitations back then. But in retrospect, when we look back, it might have been one of the earlier indications to that effect. Several other retrospective trials actually were done comparing horse and rabbit, and as you can see, most of them show the either statistical superiority or numerical superiority of horse ATG. And some of the trials that don't show that they show a very low response rate to horse ATG, 39%, as you can see in one of the studies. So in the aggregate, and there are meta-analyses that have been done to this effect, which shows that in the aggregate, the horse ATG data is actually better than rabbit in meta-analysis. What about second line? So somebody did not respond front line. How do you salvage these patients? Well, there are, repeating immunosuppression has been done for a long time, about 20 years. So what's the data? If you fail horse ATG and you try to salvage that patient, we did a prospective randomized trial, one of the few prospective randomized trials ever done in aplastic anemia, where we accrued 54 patients, so there's 27 per arm, and these are all patients who had received horse ATG and remain refractory. And about a third of patients, about 30 to 40%, actually responded to retreatment, which was kind of interesting. And alemtuzumab was given without cyclosporin. Rabbit ATG was given with cyclosporin, and there was no difference between the two arms in terms of response rate. And these patients who responded did very well, actually. So why do some patients require 2 courses to respond and some patients respond the first time around? We're not entirely sure, but the patients who respond the second time around actually did well. Only about a third of patients, but a meaningful response. What if you, so I just showed you horse ATG failures. What about if you got rabbit ATG in your first line? Well, we had a trial where we gave quote unquote standard horse ATG as salvage, meaning second line, and we saw that the response rate was about 20%. Some patients got alemtuzumab as second line after rabbit ATG failure. The responses there were very, very low. And if you give rabbit ATG followed by rabbit ATG failures, about 20% of patients respond. So the horse ATG was a prospective trial. The alemtuzumab was a prospective trial, and the references are on the bottom. The rabbit ATG was a retrospective data. So I'm just highlighting to you the differences. So here we are 20 years later doing all kinds of studies, us and others in Europe, Asia, United States, trying all kinds of more lymphocytotoxic therapies, giving alemtuzumab, rabbit, cyclophosphamide, mycophenolate, rapamycin, G-CSF, rabbit followed by horse, horse followed by rabbit, alemtuzumab followed by rabbit, and nothing seems to actually be doing much of a major difference. So we actually at the time, we're going back 10 years ago, decided to really shift our focus in terms of trying different regimens, and we pretty much abandoned more immunosuppression as a strategy, and we moved on to the stem cells. And although we thought that some patients or some cells were resistant to our immunosuppression or the added immunosuppression, we started to believe that that might not be the case because we were getting pretty potent therapies, more lymphocytotoxic, and they were not yielding better results. So the question is, can we go back to the bone marrow and actually try to stimulate the bone marrow of patients with aplastic anemia? And this is where we started to go back to the drawing board, and we conceptualized a scenario where you have in the x-axis a certain number of stem cells, more or less, which might correlate with a probability of recovery, meaning that patients who have more residual stem cells on the right side of the curve might have a higher probability of recovery versus those who have a very, very destroyed bone marrow compartment might have a higher probability of failure. The question is, can we improve that? Now, this has been tried before, has not worked. People have tried giving high doses of G-CSF and erythropoietin. Nothing seems to actually help in that regards. And we, in 2009, started to investigate, after it was approved for ITP in the United States in 2008, a class of drugs called thrombopoietin receptor agonists. Obviously, it was developed for ITP, but we in 2009 and 2010 were interested in if this could actually be helpful in aplastic anemia. We were skeptical, I have to say, but nonetheless, we went ahead and designed a trial in order to answer that question. And to our surprise, it was quite active. And it was approved by the FDA in 2014 in second line. It was approved by the EMA in 2015 in second line, and then late last year in 2018, it was approved in front line. So I'm going to show you for the next 10-15 minutes the data. So what is the data? So the use of thrombopoietin receptor agonists was developed for refractory severe aplastic anemia. Now the good news is that patients with refractory severe aplastic anemia were actually improving their survival over time, meaning that patients who were refractory back in the 1980s did very poorly. Chances of dying was very high. In the 1990s, that number improved, and from 2000 onwards, as you can see on the Kaplan-Meier curve, that number actually continued to improve even further. Why is that? Well, lots of things. Antibiotics, antifungals, supportive care, blood banking, filter products, irradiated products, transplants were getting better. We were able to salvage patients at a higher rate. Unrelated donor transplants were getting better. HLA, donor identification, high resolution HLA, molecular tissue typing to better select donors for those who did not have a matched sibling. So several things contributed here. And obviously, as I mentioned to you, some patients were salvaged with a second round of immunosuppression, which is important to mention as well. So a lot of things contributing here. So in 2010, this was the landscape, right? So for SAA refractory patients, we could give a second round of immunosuppression with rapid horse, ATG, cyclosporin, alemtuzumab. Androgens are actually not that much studied, but it's used. But we think the response rate might be about 20–30%. In some groups, that might be higher. Keeping patients on cyclosporin is really of unknown benefit. And transplants are an option. But they're associated with morbidity and mortality. So the response rate with second-line treatment is about 30–40%. As I mentioned to you earlier, androgens in unselected patients, probably not a high response rate, but if you do select for telomeropathy, meaning that they have very short telomeres, and we published this in the New England Journal a few years ago, the response rate is actually quite high, which is kind of interesting. These are just the hemoglobin, platelet count, and neutrophil. 80–90% actually in this report in patients with very short telomeres or mutations in their telomerase gene complexes. Transplant obviously can be a very important salvage treatment, although it is associated with mortality in about 5–10% of patients with acute and graft versus host disease, acute and chronic, that can occur in about 20–30% of patients, and about 10% of patients have, 10–15 can have a very severe form of GVHD. And as I mentioned to you earlier, younger patients do better. As you can see here on the upper curve, intermediate curve is those between 20 and 40, and over the age of 40, you're talking about here a 40–50% mortality rate, which has not improved over time. And this is true also for unrelated bone marrow transplantation. This is mainly data from the EVMT. So the TPO receptor agonists were not anticipated to work, but there was some rationale. We know that the TPO receptor is expressed on stem cells. It's expressed in early progenitor cells. And people who work with stem cell biology actually use thrombopoietin in vitro to stimulate hematopoietic stem cells, along with FLT3 ligand and other cytokines, stem cell factor. And in mice who are deficient, so what happens if you knock out, if you have no TPO activity in mouse? So what happens in mouse? Well, they do become pancytopenic, obviously, but they do have reduced number of stem cells. So in vivo, if you knock out the TPO receptor, the mouse become insufficient of stem cells. And what about humans? Well, there's a rare disease called amegakaryocytic thrombocytopenia, where patients do have a mutation in the thrombopoietin receptor, and they do develop thrombocytopenia, obviously, but if they live long enough, they develop multi-lineage marrow failure. So this is telling you that TPO is very important in humans and in vivo for stem cell regulation. The problem was that when we looked at the thrombopoietin level in aplastic anemia, it was very high. I mean, thrombopoietin is sky high, meaning that all patients with aplastic anemia, if you were to measure the thrombopoietin level, you'd find very high levels. So this is like giving, let's say, a patient with MDS with a hemoglobin of, I don't know, 7 or 8, and you do measure their erythropoietin level, and it's like 2,000 or 3,000. So what's the enthusiasm to give subcutaneous erythropoietin? It's not high, it's very low actually. And some of the guidelines suggest that you shouldn't even try. So we were discouraged by this, but we went ahead and tried using Eltrombopag at the time at 50 milligrams initially. And in try to overcome this high thrombopoietin level, we went up on the dose every 2 weeks. So 50, 75, 100, 125, 150. And we stopped at 150. So it took us about a month and a half to reach 150. And the primary endpoint was hematologic response at about 16 weeks. And this was given as a single agent. So the majority of patients were not taking anything else. Only very few patients were taking cyclosporin, 1 or 2. The majority were just taking Eltrombopag. And the results were actually quite interesting. Just keep in mind that Eltrombopag binds to the thrombopoietin receptor differently from where thrombopoietin binds. It binds in the intramembrane domain. Thrombopoietin, the native thrombopoietin we have in our body, binds up here. Romiplastin binds up here. So it's different. So it binds at the same receptor, but at a different binding site. So the pilot report was published in 2012 as a single agent, and about 40% of patients responded. There was about 25 patients in that first report. This was followed by a follow-up paper published in Blood a few years later, confirming the 40% response rate. You're talking about 17 out of 43. And what was interesting is that some patients had multi-lineage responses and achieved transfusion independence. So this started to give us sense that we were probably hitting a very early progenitor cell in the bone marrow, something that we did not expect to see tri-lineage responses. And this is some of the responses that we were seeing. You can see the platelet count. In most patients, about 10,000 going up and up and up. So this is platelets. We did have an endpoint for platelets, but hemoglobin, as you can see, this is in responders, and I'm showing you some of the responders also going up. So you have somebody with hemoglobin of 7 or 8, and you put him on a pill, outpatient, and a few months later, they have a hemoglobin of 13, 14. So that was a very interesting observation. And some of the neutrophil counts also improved. And if you look at some of these bone marrows, pre and post, and not all of them, but you can see that there was an increase in cellularity in some of these bone marrows, really giving you a sense that you are repopulating the bone marrow with the thrombopoietin receptor agonist. Interesting is that early on we noticed that some patients could be discontinued, meaning that they stopped the drug, especially if they had a robust recovery of their counts, and several of them actually were able to maintain off therapy, which is something we thought it was a very important observation. Great for patients so we learned that you don't have to have all patients forever on this regimen. It looks like in some patients, especially if their counts are robust enough, and if they had a very good recovery, you can stop. And how did we stop? Actually, it was a very quick taper. We stopped. We cut the dose by 50%, and if they were stable for 4 to 8 weeks, we then stopped. Remembering that the most prevalent toxicity we saw was LFT increases, and we knew that from the ITP data, so this is not something that was new. So we monitor that in the trial by following LFTs. But the rate of discontinuation for LFT abnormalities was extremely low. Oftentimes when the LFTs went too high, we were able to hold the drug for a few days or a week. The LFTs usually went down, and we were able to re-challenge patients. safely. So these are some of the criteria that we use in order to stop the medication. Platelets greater than 50, hemoglobin greater than 10, and a neutrophil count greater than 1,000. So in patients who met these criteria, we built in a discontinuation by cutting the dose in half, and if they remain stable for 8 weeks, stopping the drug. Probably the most concern we had was the issue of stimulating bad actors in the bone marrow. And who could these bad actors be? Clones. Clones that could be stimulated by Eltrombopag. So we did monitor this very closely. We did bone marrows frequently. And what we were able to observe is that in some patients, these abnormalities were detected, but we know that 10 to 15% of patients with aplastic anemia without Eltrombopag, just with a natural history of the disease, can go on to develop clonal evolutions. So we did monitor this and compare this to past experiences, and we have not seen an increase in the cumulative incidence. What we did observe, actually, and as you can see on the time to evolution, was that they probably happened a little bit earlier than we would have expected, suggesting that these are occurring earlier, which is an important observation. Now, there's a paper that was published as an abstract in 2017 and published in Blood, actually, just a week ago, where instead of the ramp-up study using 50, 75, 100, and 125, we started the Eltrombopag on day 1 at 150. So that's the dose that we have seen to be effective in marrow failure. And the primary endpoint was not hematologic response at 4 months, but 6 months. And the paper was published a week ago, or 10 days ago, no more than that. And the response rate was about 50%. There was an additional patient on this publication, so there were 40 patients, and 20 responded, which is 50%. But what was interesting is that by giving the 150 dose earlier, about 2/3 of patients, or 70% actually, had a really robust response, meaning that we could actually stop the drug in most patients, given the fact that we were stopping for robustness of response. So the overall response rate of 50% is not too different from what we have seen earlier, although the number of patients who had a robust response by starting at 150 and giving it for 6 months was higher than what we observed earlier, which allowed us to try discontinuation of Eltrombopag. So we thought this was important. And another piece of information that is important for you is that some patients responded between 3 and 6 months. So it appears that 6 months is more optimal than just giving for 3 months. And the rate of clonal evolution that we've observed is around 15%, which is what we have seen in this disease in the past. Real world data, this is data that was published by the Europeans a few years ago as an abstract form, showing that the Eltrombopag was given for SA refractory patients. About 40% of patients responded or achieved transfusion independence. There was a larger report, again published by the same group in Europe, this time with a larger number of refractory patients, Eltrombopag, which was given for at least 2 months. It was a questionnaire-based, retrospective. But the important information is that about, if you add the PRs and the CRs, you're confirming the 40 to 45% response rate. The Europeans included another group of minimum response, which brings the total response, according to this report, to about 60%. And very few patients discontinued due to adverse events, only 2 patients. This was published earlier this year in 2019 as a full manuscript. And very low rate, at least on this reporting, of progression to MDS and leukemia. So in 2019, Eltrombopag was added in the armamentarium of options in patients who had failed initial immunosuppressive therapy, and the hypothesis was that you were stimulating stem cells. But as we have learned from the ITP literature, there might be other immunomodulatory mechanisms in which Eltrombopag might be exerted. We don't know if they are important in aplastic anemia, but they're certainly not detrimental when you can increase regulatory T cells, when you can decrease interferon gamma, Obviously, stimulating stem cells is important, and we know that Eltrombopag is an iron chelator. So it actually decreases iron in patients with ITP and aplastic anemia. Now, we don't know how important that is to improve hematopoiesis. There's some retrospective reports to suggest that might be important, but it obviously cannot hurt. So there might be other mechanisms here in play. So the curve that I showed you earlier might be affected by the fact that we might be increasing a certain number of stem cells in patients with SA. The question is, can you bring this up front and you reduce the number of those patients who ultimately become refractory to IST? So the follow-up trial was obviously combining horse ATG cyclosporin with Eltrombopag, 92 patients in total. They were separated in 3 cohorts, about 30 patients in each. And as you can see, there was a little bit of difference in how these were given. The 14-day delay was given because there was a concern earlier that there might be some hepatotoxicity, but later on we did not see that, and especially in combination with cyclosporin. So Eltrombopag was brought to day 1 with horse ATG cyclosporin, given for a total of 6 months and starting at 150 milligram dose. And pay attention to this cohort 3 because this turned out to be the more optimal way of delivering these drugs in combination. And what do I mean by that is this graphic. So if you look at the OR rate in cohorts 1, 2, and 3, about 30 patients in each, 80, 87, 94, overall response rate. Remember that the response rate with horse ATG cyclosporin alone, historically, consistently, in several patients treated on protocols, was about 60 to 65%. And the complete response rate, which is only, it's unusual in IST alone with the horse ATG cyclosporin alone, went from 33% in the first cohort, 26 and 58 in the last cohort. And if you look at patients who have been treated more since this publication, there's about 90, 92 patients, and the complete response rate still hovers around 50%. So that's a very interesting complete response rate, given the fact that historically only about 10 to 15% of patients with horse ATG cyclosporin alone achieves a complete response. So here you get a sense that something different is happening, and the responses are quicker. They're responding by 4 weeks, 5 weeks, not the 10 to 11 weeks as you see with ATG cyclosporin alone. So they're getting off transfusions quicker. So this was published in the New England Journal 2 years ago, and obviously, as I indicated to you, survival is dependent on response, and at the time of reporting at a median follow-up of 18 months, the survival curve here is really good, over 95%. Very few patients died in the first 12 to 18 months, and follow-up continues in this patient population. So the clonal cytogenetic abnormality is something that was monitored in the initial reporting in 2017, and we did see some, and as we would have expected. The interesting thing to mention to you is that not all of them were associated with a dire outcome. So this is an updated table with about 150 patients in total. And yes, when you have chromosome 7, monosomy 7, dysplasia in the bone marrow, these are real, true clonal evolutions that are evolving to MDS and leukemia, usually associated with no response or lack of response or losing response. But there are patients who developed a deletion 13q, a trisomy 6, 4 years later, 2 years later, that had no dysplasia in their bone marrow, and that had great counts, either a PR or a CR. Sometimes the cytogenetics normalized. So picking up one of these abnormalities in this trial did not necessarily associate with a bad outcome. So it's important to put the cytogenetics in context of 3 things, basically. What is the cytogenetic abnormality? So usually monosomy 7 is a problem, or anything that involves chromosome 7. But that other non-chromosome 7 abnormalities might not be associated with a bad outcome. What are the other factors? Well, the counts, obviously. The person has a normal blood count. Well, probably not a major finding. And if there's no dysplasia, that also gives you a little bit more comfort that this is not exerting a really bad effect. So it's important to put these in context. The clonal evolution in this report 2 years ago showed that in 2 years historically, and then when I say historically, these are patients treated on protocols, getting the same regimen with the same criteria, using the same response criteria, same administration of ATG cyclosporin. So it's a very cohesive and consistent historical cohort. And when we compare to that, we saw that there was a very similar clonal evolution rate in 2 years in Eltrombopag treated patients. Interesting, relapse was a little bit higher in the first cohort when cyclosporin was discontinued at 6 months. The protocol into cohort 2 was amended to include a continuation of cyclosporin after 6 months. But Eltrombopag was stopped, so the protocol stopped Eltrombopag at 6 months. And that actually decreased the relapse rate significantly to about 15%, much fewer than the 50% that was initial. So the continuation of cyclosporin at a low dose, usually at a 2 milligram per kilo dose, which is a very low dose and very well tolerated, seems to prevent relapse in most patients. So more recent guidelines based on this data have actually, especially in adults, so the benefit of the Eltrombopag, when you look at the data as a whole, really seems to benefit adults quite significantly. So this is published in the New England Journal last year. So the immunosuppressive therapy plus Eltrombopag incorporated into adults, obviously FDA approved, and in several countries as well, as these filings are being made late last year and this year. The 40 years of age still used as a cutoff to decide between transplant and non-transplant. So the algorithms are starting to change based on some of the more recent outcomes. Remembering that Eltrombopag is a chelator, so it's important that you not drink this with dairy products or milk or cheese or antacids. And it's interesting that the reports showing that ferritin level goes down in patients with aplastic anemia on Eltrombopag, again indicating its chelator properties. So food associations or food instructions are very important to these patients. Otherwise, you might lose effectiveness without knowing. And keep in mind that the LFTs have to be monitored carefully. East Asian patients usually have to take half the dose, different from patients from the West, and this has to do with ethnic-based pharmacokinetics, and there's no adjustment for renal impairment. So the summary for my talk, as we reach our concluding minute or two, is that transplant should be offered to patients who are eligible for transplant based on age and donor availability. In second line, Eltrombopag emerges in the last few years as a single agent with a 40 to 50% response rate, and this has been actually seen in the real world. Keeping in mind that the more recent data, starting Eltrombopag at 150 and giving for 6 months, didn't change the overall response rate, but it put more patients in the complete response rate category. Romiplastim, it's a question I get asked a lot. There's very fewer data in romiplastim. There's some abstracts showing that romiplastim is also active. There's no license, there's no approval for romiplastim anywhere in the world. It was presented at ASH in an abstract form, and there are manuscripts that are coming out this year and next year showing that data. And more recent data shows that the addition of Eltrombopag to IST improves the complete response rate and the quality of response and the kinetics of achieving a transfusion independence and decreasing the number of patients who are labeled refractory SAA, because those patients then, when you talk to these patients, you're talking about offering them transplant or immunosuppression, and the complications starts to increase. So it's not an easy conversation to have for patients who are refractory to IST, and given that fact that only 30% of patients will have a matched sibling donor, Most patients in the world are treated with non-transplant therapies for all kinds of reasons. So obviously there's a great interest in developing non-transplant therapies. Transplant therapies as well are important, but again, in the world, most patients are treated with non-transplant treatments, and the good news is that we have able to significantly change the natural history of the disease. And what's interesting is that the more immunosuppression didn't seem to be the answer, but the addition of a drug that would work in a different mechanism and was able to be given safely with IST or immunosuppressive therapy seemed to be associated with the better results that we have achieved in the last few years. So those are the 45 minutes I wanted to spend with you, and really I gave you a big summary of what happened in the field for the last 20, 30 years, and including some of the more recent data. So with that, I'd like to conclude my time, and I'll be more than happy to answer any questions that might come through the chat. Thank you.